My name is Dr. Rachel Earls, and I will be your moderator this evening. Please direct any questions that you have into the Q&A feature, and we will answer what we can during this webinar. We will try our best, and we will follow up with a recording of this webinar after. If you have any questions following the webinar, please feel free to reach out to our team at GeneSightEngage@genesight.com. We will also put that email in the chat as well, so you can see it, but it is GeneSightEngage@genesight.com. In our previous webinars, we discussed different sections of the report, including the green, yellow, red bins, or the interpretive portion of the report, the genotypes and phenotypes results, and the gene-drug interaction chart. And then we reviewed how to appropriately use the clinical considerations when reviewing the report. So following the webinar, we received really great questions pertaining to how and when clinicians are using GeneSight testing in the real world. And so to address this question, we decided to bring in an expert panel of GeneSight users and have them walk through case studies of patients that they are treating to help create a greater understanding of when are they bringing GeneSight on for their patients, how are they interpreting the report, and how are these results being used in conjunction with their clinical decision-making tools to help inform medication selection. So before we begin, I would love to introduce our expert panel of GeneSight users. And we'll first begin with Dr. Gus Alva. Dr. Gus Alva is the Medical Director of ATP Clinical Research in Costa Mesa and Anaheim, California, and collaborates with Pacific Neuropsychiatric Specialists in Orange County. He's an assistant professor for the Department of Neuroscience at the University of California. He's a diplomat of the American Board of Psychiatry and Neurology and a distinguished fellow of the American Psychiatric Association. Dr. Alva, thank you so much for being here tonight. We're honored to have you.
Next, I apologize. It's my pleasure. Thank you for having me.
Of course. Next, we have Faye Bembry. Faye Bembry has 27 years of experience as a nurse practitioner. She holds a master's degree as a family nurse practitioner from Vanderbilt, a postmaster's degree from UT Knoxville as a psychiatric mental health nurse practitioner, and she currently works as a psychiatric mental health nurse practitioner in post-acute care for Teen Health and holds the title of clinical lead in the Southeast region. She continues to precept students from area schools and has served as adjunct faculty for UT Knoxville and East Tennessee State University. So good to see you today, Faye. Thank you for being here.
Thank you.
We have Dr. Whitney Brown as well, who is a dual board certified nurse practitioner in family practice and psychiatric mental health. Dr. Brown is a 3-time graduate of Touro University, where she earned a Bachelor's of Science in Nursing, a Master's of Science in Nursing on the family nurse practitioner track, and a doctorate of nursing. She earned her postdoctoral certification in psychiatric mental health at the University of Alabama. She's the author of many peer-reviewed publications and the co-author of the Sigma Theta Tau International publications. Her research focuses on health promotion and wellness in underserved populations through technology. So great to see you. Thank you for being here, Dr. Brown.
It is my pleasure. Thank you for having me.
And last but certainly not least, we have Dr. Ann Groover, who is a board-certified psychiatrist and the owner and medical director of the Groover Clinic in Georgia. She's an associate professor of psychiatry and psychiatry clerkship director for the Medical College of Georgia. She also serves on the clinical faculty at University Alabama Birmingham Nurse Practitioner Program, Yale University Physician's Assistant Program, and is a distinguished fellow of the American Psychiatric Association. Dr. Groover has expertise in the National Health Services Corps, working inpatient, partial hospital, outpatient, and community health service clinics. Dr. Groover, thank you for taking the time to be here with us tonight. I very much appreciate it.
Thank you so much for having me.
You're so welcome. So again, I'm going to remind everyone, please put your questions in the Q&A feature and we will get to them as quickly as we can. So we'll go ahead and get started. So to begin our conversation, I would like to ask each of our panelists, in no specific order, when they choose to use GeneSight testing. We currently know that the largest body of evidence for when pharmacogenomic testing may be clinically beneficial is in patients with major depressive disorder following one treatment failure. However, we know that there are currently no clinical guidelines that provide input on when and who to test. So Dr. Groover, when do you choose to use GeneSight testing?
Yeah, it's a great question. I would have given you a different answer years ago because I think when I first started becoming familiar with pharmacogenetic testing, I waited until I had multiple treatment failures and lots of questions and was kind of desperate to what do I do next? And I would think, oh, well, maybe I'll GeneSight test them because I don't know what other direction to take. Nowadays, that has moved lots sooner in my kind of algorithm. So really any time that the question occurs to me that I might want to know more about how this patient's body is handling the medication, I'm likely to run a swab on them pretty early after one treatment failure, but it's not very diagnosis specific at all for me, because clinically I really use it across all diagnoses, and I know the data that we have is pretty specific to major depressive disorder. But I really have, in my practice, been able to generalize that really to just the patients across all diagnoses.
Thank you. Dr. Brown, what about yourself?
I would agree with that. Utilizing it earlier has been definitely beneficial for me in kind of narrowing down the gap. A lot of times we have patients who are already desperate for finding the right fit for them, and they've been through multiple providers, and oftentimes they say to me that, you know, I've tried everything and nothing works, or no one will listen to me. And when I hear that, especially if they've had multiple failed SSRIs just to start off with, a light goes off. This may be someone with a moderately reduced efficacy, so let's dive a little deeper. But I always tell them in advance that it exists so that if we come to that point, it's not alarming when we start talking about testing.
So you kind of prime your patients with what pharmacogenomic testing is when you begin their treatment.
Yes, I want them to know that if we run into a wall or we start experiencing a lack of efficacious outcomes that we're looking for, that there is another alternative. And they may remind me sometimes, hey, you mentioned that test. Can you tell me a little bit more about that? Can we do that? And so when they do, it triggers me to go in a little bit more detail. We review the failed trials and dive in a little bit deeper to figure out what may have been contributing to this. Were they not on the medication long enough, or was this something more related to their genetics?
Do you think that increases their comfortability with it by bringing it up early?
I do. I think oftentimes people hear genetic testing and they think this is going to cost me millions of dollars, or they think this, no, oftentimes they also say, I've never heard of this before. Nobody's ever mentioned this before. And they're skeptical. And based off of history and just lack of understanding with what genetics can provide, I can understand why a patient would be apprehensive, but knowing and giving them that information to allow them to make those informed decisions early, I think helps bridge the gap for misunderstanding and getting to those results sooner.
Thank you. Dr. Alva, when do you choose to use pharmacogenomic testing in your practice?
You know, pharmacogenomic testing, I think, is quite valuable for many reasons. Typically, a lot of the patients that I see have already been seen by different doctors. So by the time that they're reaching me, they've already encountered different problems along the lines of not necessarily having had their needs met. And generally, when I ask them about, you know, labs, you wouldn't know if somebody's anemic unless you check a blood cell count, right? Red blood cell count. You wouldn't know if somebody had a vitamin deficiency, B12 or D, if you didn't do a blood test. And you wouldn't necessarily know if somebody had any thyroid abnormalities unless you checked the TSH, T4, T3RU, and so on. And so that'll oftentimes be a great bridge in speaking about genotyping assays. It's a tool that helps us along the lines of being able to figure out whether there are areas that we may not have necessarily been keen on having looked at previously, but might be quite useful for us to take into consideration. You know, for example, somebody that's failed several different therapies because of either intolerability issues or just like a lack of benefit could have been based on what's happening with their cytochrome P450 isoenzyme pathway. And I think that, you know, a test like GeneSight makes a lot of sense in having additional information before us. We certainly know that obviously phenotypes are not necessarily the best way of being able to figure out what somebody's response will be to different medications. And that's where the genotyping perspective can make such a big difference, right? So if able to, I'll utilize it as soon as possible. And if somebody's already had the testing done, it's a great opportunity for us to say, hey, look, I'm glad that, you know, this was already taken into consideration. Let's look through it and see whether we may have missed something here. And so that's always a nice fallback for people to be able to take a look at the fact that we are considering, not just one thing, and we're not just pulling things out of a hat, but we're
Right.
being methodical and intentional and scientific about, our approach.
Thank you. One narrative I'm hearing kind of on repeat now is patient education, setting the appropriate expectations early if you are choosing to use this technology, because I think there is education that's required on the part of the clinician, but also an understanding of what this test is and what it is not for a patient. So that's wonderful you're having those conversations. Thank you for sharing that. Faye, will you also share when you choose to bring GeneSight on board in your practice?
Sure. Thank you. And in addition to what everybody else has said, I'm certainly trying to utilize GeneSight testing earlier in my practice as opposed to later, which I think Dr. Groover mentioned as well. I work in a geriatric space, so I am working with older adults who, as we know, are at higher risk for adverse reactions to medications in and of themselves. So it's a population that if I have the opportunity to know their pharmacogenomics, to me, that's just vital when trying to choose a medication. Most of the patients I'm seeing have already been on multiple medications throughout their life. So it to me is something that I can do to help shorten that time to symptom improvement.
Thank you so much. We thought that the best way to share how this is used in clinical practice is to go through patient case studies of yours. So on the screen, you'll see that I am going to show case studies from each provider who is here tonight. And we're going to start with Dr. Gus Alva. So Dr. Alva, if you could kind of walk through this patient history, why you chose GeneSight testing for this patient, and maybe how it affected your decision making or solidified decision making that you were making for this particular patient, that would be wonderful. And just let me know when you would like me to change slides for you, okay?
Our current curse, right? Whenever we're doing any type of remote issues, if we place ourselves on mute, boom, we forget
I
about
have a
it.
t-shirt that says you're on mute because I work fully remote. So that happens all the time. You're not alone. You're in good company, but the floor is yours.
Excellent. Well, thank you so much. Again, a really wonderful opportunity for us to take a look at real case examples, right? So, this would be one such patient, right? A 36-year-old Caucasian gentleman who had a family history of major depressive disorder. And obviously the way that he presented was feeling depressed and anxious, having significant vegetative symptoms, being anergic, anhedonic, feeling guilty, helpless, hopeless, having a lot of difficulty with concentration, focus, insomnic, obviously libidinal drive out the door, and not necessarily being actively suicidal, but certainly having a strong sense of passive nihilism, meaning, what's the point of being alive? And obviously, this is somebody that in the past had been diagnosed with major depressive disorder, chronic, recurrent, severe, without psychotic features. When seen, his PHQ-9 was a 21, obviously indicative of a significant degree of depression. And in the past, had abused different substances, but at the present time, obviously was maintaining his sobriety, his dual diagnosis, as would have been the case previously, was obviously in remission when it came down to the use of any substances right now. And interestingly enough, in the past, he had actually utilized alcohol and marijuana as a salve to try to actually feel better. And oftentimes that's one of the fallacies that many of our patients go through, right? They try to self-medicate with exactly the wrong thing, and they're basically just, clamoring for some sort of relief. In the past, he had been seen, and as oftentimes happens, he had been treated with a laundry list of different SSRIs, including, our oldest out there, Prozac and Zoloft and Paxil and Lexapro. He'd been treated with SNRIs, including Effexor, and Cymbalta. He'd been treated with a norepinephrine dopamine reuptake inhibitor, Wellbutrin, serotonergic acting agent, mirtazapine, atypicals, including risperidone, aripiprazole, quetiapine, Geodon, certainly some lithium also thrown in there just to make sure that he had a little smack of everything, including our bad old mood stabilizer there and Rexulti, obviously with the hope of trying to actually augment the benefit associated with these medicines. At the present time, really being ramped up with a hefty dose of Wellbutrin, 450 milligrams of the XL. And the thought was, hey, maybe augmenting with Vraylar would make sense. Obviously, another medicine within the atypical antipsychotic class, FDA approved to augment the benefit associated with an antidepressant. So anyone seeing a patient like this would obviously kind of scratch their head and say, wow, everything, including the kitchen sink's been thrown in, right? So what do we do here? Another important thing is that this was a patient that was a non-smoker, and that's pretty useful because as we take a look, and thank you for advancing this, Rachel, you know, a page like this will look different for smokers versus non-smokers. And if we take into consideration, again, you know, some of the different agents, you know, obviously noted in here, we basically see that, you know, there was a smattering of different medications that he had been on. You'll note the majority of those obviously being within that red line designation. This is an important thing too, though, because whenever we have patients look through these, they oftentimes, you know, interpret these reports in a bit of a fallacious manner. You know, even if you've got something in the red line or the red column, it doesn't necessarily mean you can't use it. It simply means that you probably want to exhaust the two previous columns before you're considering that red one. And, you know, when you take a look at the clinical considerations, that oftentimes is useful in helping instruct individuals as to why they may have experienced certain pitfalls with different medicines or why they just didn't work for them, right? And whether it be that, you know, blood concentrations of a medicine would be too high or too low, you know, obviously are nicely explained there. If too high, then you'd obviously want to tweak the dosing and make it actually a little bit lower. An increase in the amount of the medicine would obviously evoke additional side effects. And, you know, if you advance over to the next slide, that actually also is illustrative of the antipsychotic agents, right? Not all of these are FDA approved to augment the benefit associated with antidepressants, but there's an interesting literature associated with, for example, risperidone that we used to utilize to augment the benefit associated with antidepressants before quetiapine and then subsequently aripiprazole and brexpiprazole and then subsequently cariprazine became FDA approved to do just that. Sometimes people will reach for other things that, you know, they feel would actually be advantageous for them. In that case, you know, this patient had also been treated with ziprasidone, for example. But obviously the same explanations noted here where, you know, we can walk people through as to why, you know, certain things might have actually been futile, or they may have actually sparked a little bit of traction for them. And let's go over to the next slide and take a look at other things. You know, obviously, you know, when you take a look at mood stabilizers, I think we went there. There we go. You know, you basically will note that, you know, in the case of lithium, there's no proven genetic markers, right? But in the case of other things that sometimes people will try to utilize to regulate mood, including things that might not necessarily have to be FDA approved, but people do use them, like Lamictal. You know, you've got different things that, you know, will subsequently help guide the practitioner as to what might actually be an advantageous move or not. So let's go over to the next one. And, you know, it's interesting when we take a look at, you know, what we have the patient on, right? If you just read this, serum level may be too high or lower doses may be required, and use of this drug may increase the risk of side effects. In the case of the patient, he was taking already a copious amount of the medicine, right? 450 milligrams, which a lot of people would just kind of like go, wow, that's quite a bit. We certainly note that, you know, the package insert of every single medicine will you know, instruct a lot, right? So the FDA doesn't necessarily chastise, you know, clinicians. They basically want to throw out language that allows us to, you know, take a step back and take certain things into consideration. Is this somebody that's had a history of seizures? Is this somebody that's withdrawing off of, benzodiazepines or barbiturates or alcohol? Is this somebody that may have had an eating disorder? Is this, whatever additional things? There are certain factors that are typically embedded within package inserts that it's not bad for us to actually keep in mind, right? And obviously, with the patient being at that high of a dose and then subsequently wanting to actually enhance the overall benefit rather than go up any further, since obviously we were already capped out, the thought was, hey, that Vraylar might actually be advantageous. Let's look at the next slide, if you don't mind, Rachel. This is also a terrific spot in which, we take a look at whether we would expect to see a particular type of a profile in patients or not, right? And so, it might be an important thing. If this were somebody that were a carrier of the short allelic form of the serotonin transporter, that would explain why so many SSRIs would have failed, right? But in this case, this is somebody that was a carrier of the long allelic form, in which you'd expect an SSRI to work relatively well. Obviously a normal sensitivity to, the 5-HT2A receptor. If you take a look at, the human leukocyte antigen, that's pretty useful too, right? For tracking the possibility of seeing whether somebody might experience a cutaneous drug reaction that might be problematic, and certainly taking a look at, where different receptors and the pharmacodynamic perspective of each individual. It's one thing to talk about how, again, different medications interact with the body, but it's also important to talk about how the body interacts with different medicines, and that's already something built in. So each one of these elements are always very helpful in trying to share information for patients. If you can advance to the next slide there, Rach. Thanks so much. This was actually very helpful too. We note that some patients might be poor metabolizers, and generally the 2D6 and 3A4 pathway are the things that come out glaringly at people, right? And in this case, obviously, if you take into consideration, the pathway being utilized by the medication currently being consumed by the patient, that would obviously be an explanation as to why there might be additional risk for somebody in reference to having an enhanced amount of the medication in their bloodstream. But also, again, patient wasn't really responding well. So this at least helps with, the navigation of being able to talk about different modalities, whether that would be, maybe an additional step, a consideration of repetitive transcranial magnetic stimulation, a consideration of something that might be more glutamatergic in nature, and so on. But at least this enhances the overall ability to be able to propagate some useful information to people and make them not feel like they fail, right? Because if you take a look at the nomenclature of what we have right now, we oftentimes talk about treatment-resistant patients, right? And we oftentimes adjudicate treatment failures, and it sounds like the patient's failing when in reality we're failing them, right? And that's where, when we have additional information, we can basically say, look, this is more of a collaborative process. And I want to walk you through all the different tools that I have at my disposal so as to be able to help you get to where you need to be. If you go advance over to the next one. And this is very useful, right? Because we basically see then, hey, maybe if there wasn't a medication that's been considered previously, and in this case, look, desvenlafaxine, again, the offshoot, the active metabolite of venlafaxine might actually be a terrific fit for you. That at least helps, with additional traction for the patient. And rather than help them or make them feel defeated, and you're already stepping into the battlefield with lost ground, you can then gain additional traction with information like this by saying, maybe we're going to hedge our bets by actually following through with some suggestions that are popping out through here. If you advance to the next, and then what we obviously did, hey, that Vraylar looks like it's going to be a solid fit. So maybe if we just shifted over from that Wellbutrin over to that desvenlafaxine, kept that Vraylar on board, we might actually come across a more advantageous outcome. And now it's not just oh, you're saying it, so it has to be. This is like, oh, we've got this roadmap, and you just helped me understand that roadmap, and I'm appreciative about that. And now I'm actually going to follow through with each one of the recommendations that you're making for me, because they make sense. And it's not just you saying something that, I don't necessarily know because I didn't do your schooling as to whether it actually applies to me or not, but this is something that's scientifically based and helps buttress the points that you're making for me. So if you advance to the next slide, Rachel, that actually helps with the fact that, there were several different things that were playing out with this patient. He was a poor metabolized from the 2D6 pathway. That might have been the explanation as to why different medicines, including the Wellbutrin, the Celexa, the Effexor, the Paxil, Lexapro, Seroquel, Prozac, Rexulti, and Abilify weren't a great fit for him, right? And if you take a look at the involvement of the CYP2D6 pathway, about 2/3 of medications, that are actually included in the psychotropic test that GeneSight has are a consideration, right? And at least a quarter of the medicines in general. And interestingly enough, the intermediate metabolism at 2C9, which sometimes gets dismissed, might have further led to higher serum levels of different medicines, including that Prozac, Remeron, Effexor that he took. And so, like I said, the game plan was, hey, we've got a good rationale associated with why I'd like you to taper off the Wellbutrin. Brain doesn't like immediate jolts. I'm not a big fan of just abruptly stopping things. But again, now at least there was a rationale of, hey, we're going to back off gradually. We're going to initiate you on what might be a better fit for you. We're going to stick with that atypical antipsychotic that is FDA approved to augment the benefit associated with. And again, it's going to be used in concordance with. And as a consequence of that, we had a really good outcome because, in fact, the patient did improve. His vegetative symptoms diminished. And, it also helped with some of the concomitant anxiety that he was having. And ultimately, the most important step was getting better functionality, right? It's one thing to say, we're going to reduce your PHQ-9 scores or your MADRS scores or your HAM-D scores or your whatever scores. But if that's not playing out along the lines of that patient being able to get back to work, doing their domestic chores or engaging socially, then what's the point, right? And so this is a great example of where the GeneSight psychotropic test, affected the patient's willingness to accept the new treatment plan and just accorded me, a little bit more runway so as to actually get the plane off the ground.
Thank you so much for sharing all of that. I have many, many comments. I'll try to keep it to just a few, but a few big takeaways I heard from your case study was don't be intimidated by the categories, read the clinical considerations. As you noted, many of them were related to metabolism for this patient, which is important in the context of dose adjustments, not do not use or avoid, just this patient metabolizes the medication differently. I also want to point out earlier in the slides, you noted that you were considering Vraylar. So this helped push forward a decision that you were thinking of in the beginning, but you were cognizant of the patient history and all the trials they've gone through. So I really appreciate your detail with this case study, and obviously the outcomes are we're all here. So thank you for sharing so much,
My
Dr.
pleasure.
Alpha. All right, and now we are going to move to Faye Bembry's case study. So Faye, the floor is yours, and direct me with your slides, please.
Okay, thank you so much. So as I mentioned earlier, I work in geriatrics. So this is fairly typical of what I see in my practice. Also, we end up a lot of times with very limited information about what has been trialed in the past. Sometimes when a person is in their 80s, they say, oh, I took something for depression years ago, but I don't remember what it was, or whatever, don't have access to records like that. So this particular lady is 88-year-old white female. She did have a past history of hypertension. She had some other comorbidities like arthritis, things like that. She was living in an assisted living facility, did have some family history of depression. She was not a smoker. Target symptoms on her presentation was low appetite, depressive symptoms, and motor restlessness. I was trying with her to ascertain, when these symptoms occurred in relation to her current med list, which we'll kind of get into briefly, but she did have a recurrent major depressive disorder. She also had been diagnosed now with dementia or with some behavioral disturbances, specifically anxiety. We did know that previous medication trials included bupropion and lorazepam. These either didn't work, or in the case of lorazepam, made her more confused, which can happen with benzodiazepines in older patients. At the time of GeneSight testing, she was on risperidone 0.5 milligrams twice daily. This had been started by her primary care doctor prior to being admitted to the facility to help with some agitation and anxiety related to her dementia. She was also on mirtazapine, low dose, 7.5 milligrams at bedtime. So in sort of when we talk about with prior to GeneSight, what our treatment as usual plan would be, based on her symptoms and depression, a consideration might be increasing her mirtazapine. So that was something that, could have been a consideration. But with her age and the treatment failures, I offered GeneSight testing to her and her daughter, and they were, happy about that. What can we do to get mom better? And offering the GeneSight turned out to be a great idea. So we did that early. So if you can look at her antidepressant panel, highlighted there in yellow was bupropion, which she had had a treatment failure of. I did not know what her doses were of bupropion when she took it before, but you can see there, similar to Dr. Alva's, we have a lot of drugs over in that significant gene drug interaction column. And if you'll notice to the side, a lot of ones. And ones, in my mind, and with the clinical consideration, really means that you're a slow metabolizer. So that in and of itself lends itself to a higher risk of adverse reactions with normal doses of medication, plus compounded the fact that she was 88 years old. So I was quite happy that we had gotten this testing done for her. So as you can see, bupropion has 1 in 6 increased risk of side effects, and serum level may be too high. And I want to reiterate, as Dr. Alva did, the clinical considerations are really highly important, because when we look at these green, yellow, red, as said previously, it doesn't mean we can't use drugs in the red, but we have to be cognizant of dosing and aware of those considerations associated with those medications. All right, next slide. Then when we look at her anxiolytic profile, pretty, standard. Lorazepam, she was in use as directed. I believe the adverse event she had experienced from lorazepam was just a side effect that an 88-year-old gets when they take a benzodiazepine. So we're often very careful about those. All right, and then thinking about what I was planning to do, or in my mind thinking, maybe if we increase her dose of mirtazapine, we're going to get some benefit for her depressive symptoms. She, as far as I could tell, she seemed to be tolerating it. But when I look at the GeneSight testing, that may not have been the best idea now that I know her pharmacogenomics. All right, next slide. Now let's look at the antipsychotics. So her risperidone was, for her age, a decent dose. In other patients, we don't consider those low doses to be very effective, but certainly in the elderly, they are. So when I saw this, I started questioning a little more. When did the restlessness start? Was that worse since she had been on the risperidone? Was it better? And the best we could tell was that the restlessness actually got worse when she was on risperidone. So that sort of helped us as we looked at, okay, what are we going to do with this patient? Not to mention the boxed warnings for risperidone in patients with dementia. All right, next slide. So interestingly, this patient did have that higher risk with the HLA pharmacodynamic genes, putting her at higher risk for Stevens-Johnson syndrome with mood stabilizers. So we do sometimes use mood stabilizers in the older population to help with agitation. So in her case, that may have been a bad idea. We wouldn't have known that had we not done this testing. So that can be important considerations when you're thinking about those medications. Okay, next slide. And this patient also with poor metabolizer of CYP2D6, as we previously noted, many psychotropic medications go through this pathway, and medications in general. So you can go ahead to the next slide, thanks. So in this patient's case, we looked at, okay, let's try to address the anxiety and depression symptoms. In her case, she had never been on sertraline as far as we knew. So we discussed that, and that was in her use as directed. Also, desvenlafaxine, as with the previous case study, was in the use as directed column. Okay, well, I think we can head on to the next slide. So, what did we do? First, we'll note poor metabolizer of CYP2D6. Patient is at a higher risk when using mood stabilizers, such as things like Tegretol. So what did we do with her? We first went ahead and, when I show the results, as many of you will find, to the patient, and I also was able to show them to her daughter, when somebody sees that they have a metabolism issue with their current medications, a lot of people are thinking, oh, I do need to make a change. And that's, as Dr. Alvis said, it kind of bolsters us in our decision making. You're not doing well on these medications. So now we can sort of see what the problem was. So what we ended up doing was slowly tapering off Risperdal. We went ahead and stopped the mirtazapine or Remeron because it was already a lower dose. We went ahead and initiated some low dose sertraline. We were able to taper this patient completely off of Risperdal and saw improvements in both depression and anxiety with the sertraline. So in her case, we were able to go from 2 medications to 1 medication, which is so important for our older adults and polypharmacy. So I fear that without GeneSight testing, we would have continued to go down a road of adverse events or medications not helping, just because we wouldn't have thought to take this away and go back to kind of an old tried and true sertraline. So that was, really in the scheme of things for a patient this age to be able to reduce the number of medications was extremely mapped for the future. Should we need more psychotropic medication for different problems that may crop up, we have an idea. If you'll go back to her antipsychotic panel there. So in her case, you know, there are brexpiprazole is now on label for agitation and Alzheimer's disease, but that may be an okay choice for her, but we would need to adjust dosing. So when you look at this, it does help us have a roadmap for what to do in the future. So I think that it can save you time. I think you take the time to do the test in the beginning. Number one, you may get people to improvement quicker in their symptoms, and then you sort of have a roadmap for the future should they need it. All right.
Thank you so much, Faye. We've gotten some questions in the chat that are relevant to your case study as well as Dr. Alva's I'd like to address. So one of them is how to interpret the numbers behind the medications in the yellow and the red. So you'll notice that some of these numbers are the same. So you see ones and sevens, ones and sixes. So what is the true difference between the yellow and the red category? It's the expected impact that we think this genetic variation may have on these medications. You still interpret the numbers exactly the same, and they are cited at the bottom of each page of the report. So you by no means need to memorize them, but you notice that if there is a number there, you go down to the bottom of the page and read what that's telling you. So many of the clinical considerations that we heard in these past two case studies were related to dosing. So as Faye mentioned, at 1 just means that serum level may be too high, lower doses may be required. So that just tells you information on how your patient's metabolizing a medication. Think of this as supplemental information for you to use in your decision-making process. As it's been stated multiple times, you know, if brexpiprazole is what she deemed the appropriate next medication, you would look at these clinical considerations and realize that this patient may need a lower dose, but that does not mean you can't use it. So it allows you to use medications across categories. So we do have some previous webinars as well that go over that in a little bit more detail. I know time is not our friend tonight, so I'm sorry for the brevity of that answer, but I hope that cleared that up. And one other question that we've gotten a couple times is related to Prestige being in the green category. Some providers noted that Prestige tends to be in the green category quite a bit. And to provide some clarity on that, Prestige is metabolized primarily by a gene called CYP3A4. So if you look on these patients' panels here, CYP3A4, as Dr. Alva mentioned, is a big player in drug metabolism. A lot of medications filter through that cytochrome P450 enzyme. But about 91% of the population is a, quote, normal metabolizer of that enzyme. We don't see as much variability in that enzyme as we do CYP2D6 or B6 or 2C19 or 2C9. Those are more polymorphic in nature. So because Prestige is primarily metabolized by this gene that's a little bit more stable, that is why you'll see it in the green category more frequently than other medications. Some of the older medications go through these pathways that tend to be more polymorphic amongst the population. So thank you for those thoughtful questions. And thank you, Faye, for letting us in on your expertise with using this panel. So next, the floor is yours to Dr. Ann Groover to walk us through her patient.
Thank you. I really love how much we can learn from these case studies. And it's interesting to me how similar some of them are and yet how different. So I appreciate so much what Dr. Alva said about the laundry list of medications that the patients have kind of tried and failed. They get a little clinical exhaustion for trying to be talked into another medicine, particularly if you're thinking about an augmenting strategy. I'm like, okay, 2 medicines when one has never worked. And, you know, I think it does, having some data to show them makes such an impact on the patient. First of all, knowing that you're looking at them as an individual person. My patients really respond to that, just that we've taken the time to do something specific to them. And also, I think it gives them hope that there's something further we can know about them and about this process that might help us get better outcomes. It's really been, you know, that opportunity that the patients see, okay, maybe there's something else, another reason to try something else. So I really appreciated that. His patient had a lot more previous medication trials than my current one does. But so this is a patient who is near and dear to my heart, 24-year-old fellow, but I've been taking care of him for quite a while. He first came to me when he was 16 and a car accident had amputated one of his legs. He was an athlete, and so we went through a long journey together, through which we were treating depression and phantom limb pain initially, but as it turns out, he actually was bipolar. And that turned out to be the bugaboo that we were trying to treat over the long term. He really adjusted brilliantly well to the amputation, but he also had some comorbidities. He had Tourette's syndrome and ADHD, both of which were pretty symptomatic from time to time. Past medical history, other than the acquired absence of a limb, included a vitamin D deficiency. And to make things interesting, he was a daily cannabis smoker, much against my advice, but was doing it anyway. He had some sporadic alcohol use, as many of our young 20-somethings do, but I don't think he was addicted in that respect. Family history was positive for bipolar disorder, also ADHD in a couple of relatives. So we had presented at this point with a lot more mood swings than usual. We were seeing a lot of ups and downs, kind of rapid cycling, but the depression was pretty severe. There was a great mixture of symptoms most of the time. His tics were quite flared up. He was having a lot of anxiety. He was actually developing some paranoia, quasi-psychotic paranoia, irritability, obviously very much impacted attention and concentration issues as ADHD at baseline, but then we start to really superimpose a lot of serious mood disorder symptoms. The cognition really was a problem, and his impulsivity, which at 24 wasn't wonderful at baseline, was really getting to be a problem as well. So previous trials, over the years, he had some stimulants, Adderall, Concerta, Ritalin, and Focalin. He was not on a stimulant at this time. Medication list at the time of GeneSight testing, he was on fluoxetine 20 milligrams. He was on Risperdal 3 milligrams once daily, and lamotrigine 200 milligrams BID. And so we were considering, because he was showing a lot of rapid cycling and mixed symptoms, considering titration of the Risperdal for better mood control, and also kind of hoping that it might help us suppress some of the tics that were flared up, maybe hoping to double dip a little bit. And considering changing it, also considering adding another mood stabilizer, maybe lithium or something, in addition to the lamotrigine, which had, when we initially added it, really helped stabilize him. So he had been doing quite well for some years on this combination. All right, let's look at the next slide. So we got his previous report, and showed that these were previous trials of the stimulants. And actually, we weren't really considering looking at this at the time, but that was just good information to have. Go ahead to the next page. All right, so medications at the time of testing, we're seeing risperidone pop up a lot over here in the red, because I think a lot of our examples have that slow 2D6 metabolism. But this is what he was taking. One other piece of information I think that's important in this case, and I think I learned a lot from this particular test with this particular patient about using the GeneSight report, because I had always been kind of adverse to doing anything in the red section. And this particular patient was loath to change medications. I mean, loath to change them, because when we first started Risperdal, it really stabilized him. And when we first started Prozac, it really fixed his depression. So at the time we're contemplating changes of this, and we get this report, Risperidon's in the red category, and I'm like, oh no, what do we do now? Also, you might notice at the top of the report, he was a smoker. Even though it's cannabis that he's smoking, he is burning plant material on a daily basis. So that is what determines that someone is a smoker versus a non-smoker. I always like to point that out when I'm talking to people about it. Doesn't matter if you're using nicotine patch or lozenges, that doesn't make you a smoker. It's not the nicotine, it's actually the daily inhalation of the burning plant material. And so cannabis smoking works as a smoker, just like, tobacco smoking. Okay, so these were his medications at the time. Let's look at the next. And there's the fluoxetine. You can see even this report has even more in the red and the yellow categories than the previous cases we saw, doesn't it? Let's go on to the next. In the mood stabilizers, he was on the lamotrigine 200, full dose of lamotrigine at 200 twice a day. And further information to look at, carbamazepine is in our moderate gene-drug interaction. That could have been on the table as an alternative mood stabilizer and still is on the table as an alternative, with the number 1 indicating that it's going to run higher than expected serum levels for that medication. And particularly important when we're talking about some of these mood stabilizers, because the therapeutic window may be a little more narrow than what we're used to using with some of our antidepressants and some of our antipsychotics. Okay, let's go to the next one. So these were his results. He has a variant at HTR2A, which indicates potential increased sensitivity with some SSRIs. That's a receptor, a serotonin receptor 2A, and also a variant at SLC6A4, which indicates he might have a moderately reduced likelihood of responding to some of those SSRIs. Okay, obvious choices that we would often use as first line for depression. So this is pretty impactful. We see normal risk at his HLA antigens and a normal response at ADRA2A, the alpha receptor. Okay, let's go on. So here we go. Core metabolizer at 2D6, as we saw in the previous cases, but complicating matters, he is also an intermediate metabolizer, slower than normal at 3A4. And I think Rachel mentioned that affects probably 90% of the medications that we use. I mean, a lot of medications, not just in psychiatry, but across other branches of medicine. He's also intermediate at 2C19, and he is an ultra rapid inducible version of 1A2. So as a smoker, he has an inducible 1A2 gene. So he's an ultra rapid metabolizer here at 1A2. And then UGT2B15, he's an intermediate metabolizer as well. So this is a really interesting, it starts to look complicated when you look at this. I think one of the things that is important to know about using the GeneSight report is you get used to all of the footnote numbers, the 1s, the 2s, the 3s, the 4s. After you do several tests, you don't feel quite so much deer in the headlights when you're looking at this report, okay? So I know it's a little intimidating to look at it for the first few times you do. One of the great things that Myriad Genetics does is offer you as the clinician a lot of support. So the first few times you look at the test, they will walk through the test with you item by item, answer all your questions until you feel confident that you know what to do with the information. And they'll do it as many times as you want. But really, I went through a couple of patients with them the first few reports I did, and it really helped me get comfortable with knowing I was interpreting it correctly and knew what to do with the information. So I told you he was loath to change medications, and I mean, he did not want to change medications. So we had to negotiate quite a bit because my inclination was, oh, I got to take him off the Risperdal and put him on something else. We had a bit of a battle about it in the beginning, but he was on 3 milligrams a day of the Risperdal. So we kept him on the Risperdal, but back way off on the dose, which was a compromise between what he wanted and what I thought I wanted. Okay, let's go to the next page. Same thing with the fluoxetine. He didn't want to stop it because it helped him so much one day at the beginning. We negotiated a reduction in dose, and we stayed on 2 red bin medications. And this is not something that I usually do. Okay, I usually would switch from a red to a green or a yellow. But in this particular case, I mean, our job is looking at the individual patient and trying to come up with a treatment plan that they agree with, that's palatable to them. And for this individual patient, it's one of the rare times that I stayed on red medications, but I think that makes it a great case. All right, and we kept him on the lamotrigine as well. So to sum up, he was a poor metabolizer at 2D6 and intermediate at 3A4. So he was metabolizing Risperdal and fluoxetine much more slowly than normal. And we know that that affects a lot of our other choices, our alternate choices, particularly when you use both of those reduced metabolism situations together. So 75% of medications on the GeneSight test affected by 3A4, and about 50% of all of the medications in general. Less likely to respond to some of the SSRIs and moderately more likely to have adverse reactions, particularly to Paxil. That's what we have insights as far as the test goes. So we reduced the dosage of fluoxetine to 10 milligrams every other day. And we reduced the risperidone dose to 0.5 milligram twice a day and continued the lamotrigine. So following that reduction, kind of letting things settle down, his rapid cycling really settled down and cleared. His agitation really cleared. The tics really reduced and got better. His cognition cleared up quite a bit. It left me thinking that, we may have had some significant toxicity with the risperidone as far as akathisia and as far as some EPS, restlessness, irritability that was masking as rapid cycling and mood symptoms when it was really potentially an excess of serotonergic stimulation in a bipolar patient, even though it was 20 milligrams of Prozac, which he had tolerated at one point. So there were a lot of things that, led me to understand dosing in this situation is a critical issue, obviously. We didn't need any further ADHD medication, so that was kind of not an issue with him. But he settled down and got much better and is still on this combination of medicines to this day.
That is incredibly inspiring. Thank you for sharing that. One thing I picked up on in particular is how this helped with shared decision making. As you mentioned, you got to give a little, it's a dance. And so helping a patient to understand maybe why this had happened and helping you to kind of meet him where he's at, that was incredibly inspirational. And yeah, I am a little bit speechless. That was wonderful. Thank you so much for sharing that. And our last, but certainly not least case study will come from Dr. Whitney Brown. So Whitney, the floor is yours.
Thank you. So this was a 32-year-old Caucasian male who came to my practice, and his chief complaint was anhedonia. He said he just didn't have joy anymore. And so anytime a male walks into my office, they have my undivided attention because I know that the attention span of especially a young male, sometimes they're looking for rapid results, and you have a small window to make sure that you are as accurate as possible to get them some results so they'll come back and continue their treatment plan. So this particular patient was actually the son of a business owner, and this patient was actually preparing to inherit a company from his father. However, due to the state that he was in when he came to see me, his father had rescinded that opportunity and given it to his older brother. And so that set him into further depression and frustration. The patient experienced excessive worry. He had overthinking. He was shutting down consistently in the appointment. He cried. He essentially had reported broken sleep and racing thoughts and ruminations and feelings of worthlessness. The patient was also having nightmares, and he expressed that he had experienced raw rage. So when he initially came to see me, I didn't have those records. And so as we talked a little bit more and he shared more about his irritability and his isolation, I started to gather a little bit more about this, and this essentially was bipolar disorder. So when he came to see me, he had mentioned that he had been on previous medications, an excessive amount of trials, and that he was currently self-medicating. The patient did have a past medical history of hypertension and hyperlipidemia. This patient was pretty tall also, and he was at least 220. So keeping an eye on the medications that I prescribed him, I wanted to take in consideration his height and his weight and his current situation. But the patient had been utilizing a friend's Klonopin, 2 to 3 milligrams. He, again, this was not prescribed, but he consistently used it. He said that he had been on Remeron in the past, but the Remeron itself made him sleepy and hungry, so he stopped it. He had also been on Lexapro, and he mentioned that it made him feel numb. So he tried for as long as he could, but he also stopped that. He expressed that he had been on lithium, and it has been coined the gold standard, but essentially he said it didn't work, so he stopped it. The patient had been placed on lithium when he was hospitalized. And when he was discharged, he discontinued it on his own. He also mentioned that he was on Zoloft, and actually Zoloft was the medication he was on prior to the lithium, which led to the hospitalization, as he mentioned that it made him manic But again, he wasn't on any other medications. He wasn't on a mood stabilizer. And so he was placed on trazodone at some point. He found it helpful, so he took it on occasion until he ran out of his prescription. And then he also had tried Cymbalta, which he mentioned it just didn't do anything for him, so he discontinued it as well. He did report that he had been on Caplyta. Caplyta made him irritable, but he stopped it as well. So when I saw this patient, he was on nothing, no medications whatsoever. And I asked him, what brings you to see me today? Ideally, what is it that you're hoping that I can help you with? And again, just referring back to his quote, raw rage, and I don't feel any pleasure. The patient was a smoker. He actually smoked marijuana, and this was on a daily basis. And he mentioned that he was doing so to help him reduce his racing thoughts at night so that he could get some rest. And he mentioned he also had a history, family history of some diagnosed and some undiagnosed delusions and schizophrenia. So again, when the patient came to see me, he was on nothing. And ideally, I wanted to come up with an idea to stabilize his mood, but also give him some pleasure and joy, but not too quickly without stabilizing that concern about the raw rage. And we discussed the potential of starting on Lamictal. And then we also discussed the possibility of going back to Caplyta, since he mentioned to me that he didn't mind it, but he felt that the irritability was there. He couldn't remember the dosing that he was on, if he started on a 21 or a 42, and how long he was on it. So I considered revisiting that, also with it being weight neutral in concept with his hypertension and hyperlipidemia. Next slide. So again, this patient was a smoker. So again, I believe that was Dr. Groover that mentioned about the polycyclic aromatic hydrocarbons that come out with the daily use of burning plant material. And this patient's green category highlighted that he had been on trazodone in the past, and he mentioned that it was helpful. So this was able to explain why he felt the benefit from the trazodone. It was in the green column, indicating that he could use this as directed and that he would have the outcomes that we would anticipate based upon his genetics. In the yellow column, you will see the moderate gene-drug interactions, indicating that we need to be a little bit more cautious, slow down, and consider our clinical considerations. And as you see here, both of these were 4, indicating that he had a moderately reduced efficacy to Lexapro and Zoloft. And he mentioned that the Zoloft was what caused the manic episode, but he could not recall the dosing. So oftentimes we as healthcare providers, when we're not getting that initial response, we typically increase the dosing. And without having the GeneSight report prior to the treatment plan that he had experienced, it's likely that the dose continued to be increased until the outcome was achieved. But essentially he experienced the mania, which led to hospitalization. Lexapro, he stopped the Lexapro because he mentioned that it made him feel numb. And so he discontinued that at 20 milligrams. And so it was already increased, but he wasn't getting those needed outcomes. As it pertains to Cymbalta and Remeron, he complained that the Cymbalta wasn't effective. And as you can see, it has a number 2 as a clinical consideration, indicating that the serum levels may be too low. And so again, he could not recall the dosing, but he had already been through several medications. So at this point, this could have just been the concept of, I have tried everything and nothing works. So he also had been on Remeron. And during the time that he was on Remeron, he complained of it making him sleepy and increasing his appetite. And again, I told you he had a history of hypertension and hyperlipidemia. And with Remeron, we do know that it has the potential to make people sleepy, which is often why we utilize it. Next slide. Okay. And the Klonopin, as you can see here, the smoker label at the top, the Klonopin is under the use as directed category. And that is specific because the patient was using a prescription that was not his. but he consistently used it. And he told me it was the only thing that worked. And it was the only thing that we found to be in the green for him. So he was utilizing this to reduce the anxiety that he was also experiencing, and essentially utilizing the marijuana to help him sleep at night. So the self-medication technique that he was utilizing, while it may not be therapeutic in nature, it was the only thing that he found to treat the symptoms on his own. As you can see at the bottom, lithium, no proving genetic markers. And so he mentioned it didn't work and he did not have any good outcomes. But again, we do not know the time frame in which he allowed it to stay in his system. Also with lithium, we know that lots of blood work trying to make sure that the patient is staying compliant. So at this point, the patient had been through multiple medications and he was losing hope. And hopelessness was definitely on his list of complaints as well. Next slide. The patient had also been on Abilify in the past, and he complained of weight gain. However, you see that Abilify is in the green category, the uses-directed category. There's no genetic variation indicating that Abilify won't have positive outcomes. However, weight gain is a known side effect, so we know that this is just not a genetic factor to take in consideration. While Abilify may give him good outcomes, if he wasn't pleased with the weight gain, then ideally he stopped it. Again, Caplyta was the medication that we discussed prior that he had been on, and he complained of irritability, but we now know that this was not a genetic factor. The irritability was likely the untreated or the dosing that he was on and the time frame that he allowed the medication to stay in his system. So we discussed revisiting that at the time, and while Caplyta is in the green here, we also talked about some other alternatives. Next slide. So when I saw this patient, he was on nothing at the time, but he was willing to start something new. And so when his genetic testing came back, it allowed me to see that he had a reduced response. So SLC 684 was impacting his ability to absorb the Zoloft and the Lexapro. And next slide. Again, we mentioned that the patient was a daily smoker, and due to this, he did have the highly inducible CYP1A2 star F1 allele, and that prevented him from absorbing the medication the way that he would need to in certain circumstances, but he wouldn't know that smoking was going to impact his ability to absorb. He also wouldn't be able to tell us that his genetics, as he was not able to clearly have a collection of family history, because he mentioned that his mother had an undiagnosed delusional disorder. And so stigma played a big role as well in his family history. And then we discussed starting Lamictal, but as you can see here, he had a UGT 1A4 factor here, which indicates that he was an ultra rapid metabolizer. So if we were going to start him on Lamictal, he was going to break that down more quickly than ideally we would like him to. So when the report came back, oh no, you can go to the next slide. When the report came back, I assessed that Lamictal might be a better option for him, considering the symptoms that he was complaining of, and we placed the patient on Lamictal. So, I'm sorry, Latuda. Lamictal was the original plan of action, but due to the genetic variation that we found, we went with Latuda instead to help stabilize mood. And the patient came back and was happy as a lark. He told me it was the best he had felt in a really long time. And in saying so, while he was on the Latuda, he was skeptical initially. When we did this test, I don't think he fully understood what the outcomes would be and how we would utilize it. But at that point, he just trusted that he had tried everything else on his own and he wasn't getting those results. So when we reviewed the outcomes and started him on the Latuda, he came back and expressed that his mood had improved. He also told me that he was sleeping better. His energy was great. He had less irritability, and his wife had commented on this as well. The patient also had such a notable change that the father told him that he had reconsidered that position and that he was back in line for the succession of the company. The patient actually, it took him about 3 months, but he actually was able to get off the Klonopin. And we did urine drug screens to each appointment to ensure that he was being compliant and accountable. And he's doing really well now. Very excited about the outcomes that he had. But without this, it would have taken a really long time to achieve these goals. And as many of you know, it can take 4 to 6 weeks before we see the effects of an SSRI. And 4 to 6 weeks, if I told you to hold your breath for 4 to 6 weeks, that's a really long time. So cutting down the time that it takes to get some outcomes that are beneficial for our patients also allows us to save our patients money. They have to already pay a copay when they come see you. They already have to pay medication fees at the pharmacy. And if you change a medication, they're having to do that again. So if we can reduce the time in treatment and have a better idea about what is going on internally, then I am all for that. And I often use the reference that imagine genetic testing or GeneSight as a genetic X-ray. You and I could take the same test, but the results would be completely different. And I believe Dr. Gruver mentioned too, having that individualized conversation with them about what it can do for them. It's something they can't tell you, and they wouldn't even know it was relevant because they don't know it's happening. So providing them this information, especially for generational concepts and treatment. We know that research shows that first-degree relatives have a positive outcome to medication management. So if someone is doing well, they may tell another family member who doesn't know they have a genetic variation as well. So just bridging the gap, reducing the treatment time, and offering our patients objective data to support their treatment.
Thank you so much, Dr. Brown. And you really did a masterful job of driving home a point that I wanted to make sure we shared with our attendees, that pharmacogenomic testing is meant to be used in conjunction with all of a comprehensive medical assessment and all of the clinical factors you typically use to inform medication selection. So she talked about hyperlipidemia, talked about his diet, his weight, things to consider, his family history. All of those things are still going through your mind when you're selecting medications. This is just supplemental information for you to use to assist with that process. So thank you so much for so masterfully sharing that and how you thought through where pharmacogenomics would fit in this patient's treatment. I have a few more questions. We have a few in the chat. One of them is around, how are you integrating this into your practice? So what does your process look like? So Dr. Alva, we started with you. We'll bring it back to you. How do you do swabbing in your patients? Do you identify patients for PGX testing? Do you have your staff educated on that? How does that work for you?
Well, both. So you know what, I'm actually, well pleased to be able to work and collaborate with another MD, 2 nurse practitioners, and 3 PAs. We generally have an opportunity of actually doing reviews every week on all the patients that we see. So, this actually pops up a fair amount. Yes, I do swabs myself. I obviously have my front office staff help out with that if we're sort of in a hurry. But oftentimes it's useful to actually take that that step oneself, right? And to demystify a process and to simply say, look, all you have to do is rub the inside of your cheek 10 times each side, and that's about it. And they're like, what? That's like magic, right? It's like, well, no, it's not, but it's basically getting some DNA material that we're going to be able to send out, and then all of a sudden we're going to be getting a report on that. And so it's nice. It's nice to basically have a team that is sensitized to the availability of tools, right? And we have to make do with every single one of the tools that we have. Think about trying to, hammer a nail with a screwdriver. That's not necessarily going to work all that well, right? But if you've got a hammer, and you're going to get the job done.
Thank you. Do any of our panelists have a different process for how they've integrated PGX testing into their practice, or have any comments on that?
I typically swab them myself as well, because I've found I can do it so quickly. I just keep the test kits on my credenza behind my desk. And so as I'm discussing it with them and talking about what some of our informed consent process might be, I'm giving them the informed consent to sign. I'm filling out the envelope and swabbing them, and also getting, a little bit of, closer face-to-face observation of other aspects of their, physicality. So it's something I usually do when they're face-to-face with me, but I do quite a lot of telemedicine these days as well. And so I will have patients, when we decide to test and it's a telemedicine consult, I have them swabbed by my MA. When they just stop by, I will fill out the envelope and give the test kit with the patient's name to my MA and say, whenever they come by, swab them and stick it in the envelope and send it. So, it's been remarkably efficient for me most of the time just to swab them myself, but sometimes they'll come in. Occasionally we'll actually send it to their house as well, directly from GeneSight. I prefer to swab them in-house because I think it just helps. It's a good thing for us to perform for them. And plus we know the swab gets done correctly, and we know it gets done and sent off when we do it ourselves. So I know to go look for it in a couple of days in terms of the result, but pretty quick and easy.
I agree. I have a combination. If I'm right there in front of the patient, it's really quick just to swab them myself. Sometimes the staff at our assisted living or nursing home, I'll ask them to do it. Occasionally I'll be seeing a patient and need to swab them and they're eating lunch. So I may have to leave it and say, hey, can you obtain this swab for me after? And I find that people are usually relieved it's not a blood test. So I'm with everyone, oh, I just have to swab the inside of my mouth. That's no problem.
Thank you. We've got questions about turnaround time. So the typical turnaround time for a GeneSight test, I guess, Dr. Brown, let's talk about what is the typical turnaround time you've seen for GeneSight, and how do you integrate getting the results into patient care? So if you meet with the patient, decide to do GeneSight testing, what is that next step once you get the results?
Yes, I have a little area on my checkout slip that says we will return in 2 weeks after we do the genetic testing. Oftentimes when I swab in house, and I do it myself, I swab in house and I explain to them we're going to seal this, and I walk the sample up to the front and leave it with the front office so FedEx can pick that up. And so it's a very quick turnaround. 72 hours is as long as I've ever had to wait. Even over the weekend, I have entered information and the results populate. So it's really quick, it's really efficient. And when the patient comes back, I'm able to show them. There's a tab at the top on the portal to allow me to just click a button and send them the results, and they can open that and they can look at it while we discuss what I'm looking at on the screen. And I have a sample report in my office that I show them in advance so they know what to look for. And we just kind of go over the previous failed trials to identify why it did not work out well, so that they can understand the reason that I'm making the new selection for their medication. And patients tend to be very excited about it because it's genetic testing. They say it's very cool. It's very first century, 21st century, and they love it. And so I'm excited to share it with them, but I love having a visual aid so that they can see why we're doing what we're doing. And anytime we have a really complex situation, I just tell them, hey, if it's something that you want more information about, we can always call the hotline.
Thank you. And one last thing I'll add, when she's referencing the hotline, we don't have it up on the case studies, but on every GeneSight report on the top right of each page, there's a 1-800 number and an email address. GeneSight has a team they're called the Medical Affairs Team. They're a team of MDs, PharmDs, and PhDs, and their entire job is to support clinicians. So we can help. We're available from 8 to 6 on that hotline. You can also have a person who lives in the region near you who you can get their phone number and their email. We can walk you through results. We can ask you questions that you have. Dr. Gruber mentioned her first couple of reports, kind of walking through to make sure, am I interpreting this correctly? Am I seeing this the right way? our entire team is there for support. So please use that resource. That is why we're there. That's our whole job. So I'm glad to hear you say that, Dr. Brown. But with that, I think we have answered all of the questions in the chat. So I am going to sincerely thank all of our panelists from the bottom of my heart for your time, thoughtful questions, attention. This webinar will be available as a recording on our YouTube channel as quickly as we can get it up. And I want to just really thank you again to the panelists who've taken the time to share their knowledge on GeneSight testing, and thank the attendees who took time out of their life to listen. We appreciate you guys seeking out further education, and we really appreciate your time. So with that, I will wish everyone a good night, and thank you so much.
Take care, guys.
Have a great night.
Good night, everybody.